It is a great honor to have our next speaker, Dr. Mary Ambach, talk. She's a physiatrist, interventional spine fellowship trained, also in privademics. She's got her own clinical practice and is an adjunct professor at UCSD. And similar to Dr. Sussman, is a leader in orthobiologics research and a sought-after teacher. You're about to hear why, and happens to be the president-elect of the Interventional Orthobiologics Foundation, IOF. If you haven't heard of IOF, look them up, write it down, go to the conference. It's a great honor to introduce Mary.
Thank you, Mike. Good morning, everyone. Everybody awake? Thank you for being here. I'm Mary Ambach. I will be presenting on the evidence for intraosseous orthobiologics. So these are my disclosures, nothing that affects the content of my presentation. So while I was researching the literature for this presentation, there were questions that I wanted answered. So first, is there evidence that adding intraosseous to an intraarticular injection or intraosseous injection alone better treatment than an intraarticular PRP or bone marrow concentrate for knee osteoarthritis? Second, is there evidence for positive structural changes in using these subchondral biologics? Third, is there evidence to show that one biologic is better than the other, specifically bone marrow concentrate versus PRP? And lastly, is there evidence to show positive and negative predictors of successful outcome with this treatment? So let's just start with PRP intraosseously. This is a randomized controlled clinical trial of 86 patients with moderate to severe osteoarthritis, and they were randomly assigned to one of three groups. The first group was intraarticular and intraosseous PRP. Second group was intraarticular PRP, and the last group was intraarticular HA injection, hyaluronic acid. They used a leukocyte-rich formulation of almost 5 billion dose with a volume of 6 ml. So what they did was, for the intraosseous group, they injected 2 ml into the subchondral femur, 2 ml into the joint, and 2 ml into the subchondral tibia. And for the intraarticular PRP group, they injected the whole 6 ml volume into the joint. So they did an 18-month follow-up, and they found that the combination of intraosseous and intraarticular PRP had superior outcomes than the intraarticular PRP alone or intraarticular hyaluronic acid injection alone. So if you look at your graphs, the blue line is the combination IO and IA treatment of PRP, and you can see that there was lower pain scores at all all the time points, and so is the same with the WOMAC scores, which is better in the combination treatment than the single treatment of the intraarticular biologic or HA. So if you look at all the published RCTs on subchondral bone marrow concentrate injection for joint osteoarthritis, majority, if not all, of this study or this work is done by one person, Dr. Philippe Hernigu. He is an orthopedic surgeon from France, so we will be discussing most of his work. So this is the first RCT. This is 60 patients with varying degrees of osteoarthritis, and they had bilateral knee osteoarthritis, and what they did is they injected one knee with intraarticular PRP and the other knee with intraosseous PRP. They injected a 20 ml protocol wherein they injected 10 ml into the subchondral femur, 10 ml into the subchondral tibia for the IO group, and then they injected the whole 20 ml into the joint for the IA group. And they had a follow-up of an average of 15 years. So this was 13 to 18-year follow-up period. So if you look at your graphs on the right, the blue line is the subchondral treatment group, while the red line is the intraarticular group. And you can see that the pain scores at all the follow-up intervals are better in the subchondral group, and so is the synovitis, which is also better with the subchondral group. At 2 years, they found that the IO group did better clinically, not just in the pain score, but also in the knee society score, which is a functional outcome index, and in the synovitis of these patients. There was also evidence to show that the cartilage volume increased. It's small, it's 2%, but it's still a positive finding, while they didn't see this in the intraarticular group. At 15 years, they found that only 20% of the IO group versus 70% of the intraarticular group underwent total knee arthroplasty. And so their conclusion was that the intraosseous bone marrow concentrate was more effective than the intraarticular bone marrow concentrate in postponing total knee arthroplasty. Second RCT, again by Dr. Hernigo and his team. This time, these were patients with moderate to severe osteoarthritis, bilateral osteoarthritis, who were planned to undergo a staged total knee arthroplasty. So what they did was, during the surgery for the TKA for one knee, they did a subchondral injection of the bone marrow concentrate on the other knee while the patient was sedated and out for the procedure. And they also followed the same 20 ml protocol, followed them for 15 years. And they found that if you look at your graph on your right side, during the first 6 months, the surgery group had better pain score, but after the 6 months, all the way through the 15-year follow-up period, that the subchondral group had better pain scores. It wasn't included in here, but when they were asked which knee they preferred, more than half of the patients, 75 out of the 140 patients, preferred the knee that had the subchondral group rather than the TKA knee. They also had evidence to show that the bone marrow lesion improved, the cartilage volume increased, and out of the 140 subchondral knees, 25 of them eventually underwent total knee arthroplasty during the whole 15-year follow-up. Similarly, on the TKA knees, there was a similar incidence of 21 out of 140 of these knees underwent total knee arthroplasty. They also found that there were independent risk factors that were found that were predictive for total knee arthroplasty. And these were, as Dr. Sussman was saying a while ago, the larger bone marrow lesions were found to be independent risk factors for total knee arthroplasty. And in this study, they found specifically more than 3 cubic centimeter in size, and also severe malalignment of that hip-knee angle were independent risk factors for TKA. The severity of the osteoarthritis and the age did not correlate for an increased risk for total knee arthroplasty. So their conclusion was that the intraosseous bone marrow concentrate was able to postpone, or even in some cases avoid, total knee arthroplasty in the contralateral joint of these patients with bilateral knee osteoarthritis. This next RCT is 30 patients with bilateral knee OA. This time it was due to osteonecrosis from prolonged steroid use, who eventually developed osteoarthritis. They did the same protocol of doing TKA on one knee and the subchondral BMAC on the other knee. They injected double the volume of the bone marrow concentrate as in the prior study, and they followed them for 12 years. And they had similar findings. There were improvement in cartilage volume, improvement in the bone marrow lesion. Patients preferred the bone marrow concentrate knee better. 21 out of 30 of them did, and 9 out of 30 preferred the TKA knee. And for subsequent total knee arthroplasty at 12 years, only one of the bone marrow concentrate knee eventually underwent TKA, versus 6 out of the TKA knees had a revision surgery. This next RCT is on hip osteonecrosis. And they compared, this is 125 patients comparing core decompression, which is a standard treatment for this condition, versus subchondral bone marrow concentrate. And I included this to show that the subchondral bone marrow concentrate not only improved osteonecrosis in the MRI, but it also improved histologically, showing better bone formation and better neovascularization in the subchondral group. So as you can see on your right, there was 35% new bone formation with the subchondral group versus only 4% new bone formation for the core decompression group. So how about comparing BMAC versus PRP? There's very limited evidence. In fact, there's no human clinical trials that's published that I found comparing these two, but there's preclinical study. This is a controlled lab study of 4 to 6 rats comparing BMAC versus PRP intraosseously, and they found that the bone marrow concentrate was similar to PRP in preventing cartilage degeneration and also in decreasing inflammation, but they also found that the bone marrow concentrate was better than PRP in improving pain relief. So they measured the biomarkers, and there was more inhibition of the pain proteins, CGMP and the substance P in the synovium, in the infrapatellar fat pad, and in the subchondral bone. So this is a summary slide of the 5 randomized controlled clinical trial showing high-quality evidence on the safety and effectiveness of intraosseous biologics, namely bone marrow concentrate and PRP, with 2 to 20-year outcome data. So going back to my questions, there is evidence to show that intraosseous bone marrow concentrate and PRP, and even in some cases adding it to intraarticular, providing superior outcomes than intraarticular alone for knee osteoarthritis. And there's also evidence of positive structural improvement, whether it's bone marrow lesion decrease or improvement in the inflammation or improvement in neovascularization, bone formation, and improvement in the cartilage volume. There is early, although very limited evidence showing that the bone marrow concentrate might be a better biologic than PRP, although we need to study that further. And the negative predictors for successful outcome for this treatment includes large bone marrow lesions and severe malalignment of the hip-knee angle. That ends my presentation. Thank you.
Beautiful. Just as important.